Uh, Thank you for this warm welcome today, this morning, and it's a great pleasure always to be with the IHMR faculty and the students, whether it's at your, your institute itself or here outside. And it's my great pleasure to be here with the very distinguished panel to moderate this session. I would now like to welcome Dr. Chandrakant Laharia to open the session with his presentation.
I don't see my slides here, so. Good afternoon, I guess, yeah. So good afternoon, everybody, and welcome to this first technical session. And I cannot see my slides, so I have to go by the flow. Okay, so this is right here. And this will work on this one. This morning, you heard from three speakers in inaugural session about key aspects: Sustainable Development Goals, universal health coverage, primary health care. And the discussion was that this is a repackaging of what was being done. I would say yes and no, because things cannot be drastically different in a one go or all of a sudden. But at the same time, when primary health care was declared, I was not born. So there were people who were growing up with the primary health care, but when Millennium Development Goals came, I joined my medical school or medical college. So I was growing up with the things which I closely learned was Millennium Development Goal and, of course, primary health care. So for my generation, Millennium Development Goals was a discourse. Today in 2015, or beginning of 2016, when you are in college, there are sustainable development goals. So in a way, every generation of public health leader or students need something to associate with them. And I think SDG or Sustainable Development Goal is something which you can recognize for next 15 years. You can start working on those SDGs, and you will be the leader in this area, of course guided by primary health care and Millennium Development Goals in the backdrop. So in this background, that this is repackaging or not, I would not go into debate, but there is something which you can recognize yourself with. That is SDG, something which I could recognize with MDG, and something a generation earlier could recognize primary health care. UN-led process, and countries were informed about the MDGs later. So countries joined the process later on. But Sustainable Development Goals have been designed in discussion with countries, so countries were involved for the last 2, 3, or 4 years. So that's a major change in MDG and SDG. In MDG, there was a focus on developing countries only. Mainly, they were talking that what developing countries should do. SDG is about all the countries. It's uniform goals. In MDG, there were 8 goals. 3 were related to health, 21 targets, 6 were related to health, 60 indicators, 21 related to health. In SDG, there are 17 goals. 1 is directly related to health. There are 169 targets, and 13 are related to health. One of the key critique of SDG, there are too many. But the point is not what is the number of those SDGs. The point is that whether the things which we want to do are being covered or not covered. So SDG perhaps cover those aspects. One more change in SDG that MDGs focused upon quantity. They talked about 2/3 reduction of under 5 mortality, 3/4 reduction in maternal mortality, but SDG also focus on quality. They don't talk about quantity only, they talk about quality of education over a period of time in life course. So there is a focus on quality in MDG and SDG. So there are improvement. How MDGs are moved to SDG. So these are the 17 SDGs on your slide in front of you. The summary is, look at this way. The first 6 on the top of lines, 1 to 6 SDG are continuation of MDG. They are social sector related goals, which is poverty, health, equity, education. So one combo. There are many, but then they are more specific as well. That's the opportunity through SDG. Coming to SDG, goal 3 of SDG is on health. There are 8 indicators. You don't have to read the indicator. The key thing is that one of the indicator one of the target number 3.8 talks about universal health coverage. The thing is that India is a signatory to Sustainable Development Goals. So India has agreed to do these goals. At the same time, goal 3, and by that default of agreeing to SDG, India has also agreed to health goal and target 3.8 to achieve universal health coverage. So any discourse or discussion which need to be taken in India on UHC will come through the SDG. So as a health professional, we have to be aware of both Sustainable Development Goals as a whole, goal 3, and any discussion on UHC should focus upon target 3.8 SDG combined, and there are some other activities. So I'll not go in detail. You can collect this presentation later on. Having said that, it doesn't mean that only goal 3 in SDG is related to health. There are other goals, there are other targets which are directly or indirectly related to health. So you can see end poverty, somehow reduce malnutrition, undernutrition, and help in improving health outcome. There are ensuring availability of medicine supply, improving water, sanitation. So there are other targets which are linked to health. So we should not say that only goal 3 is related to health. There are many goals and targets which are linked to health. In summary, it's related to 10 other goals and 17 other targets which contribute to health. I would not read this thing. This is like just a broad overview on SDG. Moving quickly to universal health coverage. Universal health coverage, my colleague, Dr. Irina, would be talking about this in more detail, but the summary is that UHC talks about providing, increasing access to quality health services to additional population at the cost which people can afford. So 3 things are there: increasing access to the populations, increasing services, and at the cost community can afford. But this is not about that 100% of people need to have all the services at no cost tomorrow. This is UHC is about journey that countries, if India provide healthcare access to 40% or 50% of people, then it should move to 60% a year later, 70%. So to go in a direction that 100% of people should have access to health services at the affordable cost over a period of time. It's not talking about tomorrow or 5 days later, it's a 10 years or identified period. But the intention is more important here, that countries or states should strive to move to provide increased access, increased services, and financial protection. The idea is to reduce the gap, reduce inequalities, improve quality of services. So what is key? And that's what I want you to remember. It's a journey that countries or states should move or make a progress in that direction, and that's what universal health coverage is. This is one of the very famous cubes some of you might have seen. It talks about that on the x-axis, once you see that some population is covered. The inside box shows the existing reality for any country. Like in majority of the countries, access is only to limited number of people, and it should move to the left direction. So more people should have access. Number of services which are provided also very limited, it should increase. And third dimension is financial protection, which means people should not be, first thing is, which does not mean that everything should be free, but which means that people should be paying for those services within their ability to pay, and nobody should get impoverished because of paying for healthcare. So allowing them to pay in their paying ability. So that's a broad overview of UHC. In the current reality in majority of countries, somewhere inside cube, it could be little bigger or smaller, but inside cube, and ideally is outer cube, a bigger cube. An important journey in that direction. In various countries, and this is one of the framework from once upon a time, Government of India was thinking of National Health Assurance Mission, that the program, health program which should be designed in a way that it should not be focusing only on component. It should be focusing that how to increase access to services, how to increase number of services, and how to provide financial protections. For example, free medicines and diagnostics, help reducing out-of-pocket expenditure, and people will not have to pay beyond their ability. So when designing any national program or state health program, countries should focus on all dimensions, and that's the key focus of EHC. Quickly moving to third concept, which is urban health. This is one area which has not received sufficient attention in the country, though each one of us recognize that this is important, because urban population is increasing, because urban health indicators, and especially in urban slums, are poorer than many of the rural indicators. So that's why we should pay attention. Urban population increasing, urban health indicators poorer, and there are many challenges in urban areas. And what I'm reading, this slide is from a Government of India National Urban Health Mission Framework for Implementation. It has well identified the challenges in urban health. It talks about that the public health system in urban areas is weaker, which is a reality, because initial focus of Government of India was on setting primary health care set up in rural areas. So urban areas were largely neglected. And this is in government document. Everything which is written on this slide and next slide is from Government of India document. The challenges in urban area are poor functioning public health system, poor sanitation, contaminated water, poor environmental health, poor housing, unregistered practitioner, public health planning capacity of urban local body limited, large number of private sector provider, problem of targeting poor through the below poverty line card when those cards are not available. So you cannot identify poor solely basis of some cards. Multiple agencies working, but no convergence between different agencies within health and outside health, like women and child development, water supply, sanitation, PhD. Other challenges are that Dr. Rakesh Kumar mentioned about adolescent health, but there is no counseling system, no engagement for the adolescent. The tertiary and secondary care facilities are in urban area, but they are overcrowded, and there are primary health care facilities which are there underutilized, drug abuse and alcoholism, many slums, domestic violence. The key thing is two. One is urban health challenges are much different from rural health challenges. And second, there are additional challenges like slum population, environmental pollutions, and weak infrastructure, which you don't see that frequent in rural area. So with these two challenges, that there are additional challenges and there are weak infrastructure, there is limited attention. The key thing is that when you and all of us talk about urban health, we should be focusing upon that the strategies which have been applied in the rural area are not going to deliver the results in urban health setup. So for urban health, there have to be de novo strategies which are based upon the local understanding of urban area. That's one point. And second point is that, for example, some of you would have been studying rural health mission, national rural health mission. And the same model which has been used for rural health mission is applied to urban health. It will take the same amount of time, like 10 years, the way it has taken for rural area to deliver the same kind of result for urban setup. So something innovative, understanding local needs need to be done for urban area if the urban changes or urban health need to be improved drastically. That's broader view. But having said that, universal health coverage is for both rural and urban areas. And if universal health coverage has to be achieved in the country, equal and sufficient and timely attention need to be paid on urban health as well, which is not perhaps being paid to the extent it should have been. That's my third component. Now moving to the last and fourth component of my talk, which is a public-private partnership. And there is a specific reason I'm talking about public-private partnership in this city or this state. You know that in India, private sector is a major provider of healthcare. Primary healthcare, secondary healthcare, tertiary healthcare, but mainly primary healthcare. 80% of total outpatient are seen by private sector, and 60% of hospitalization are in private sector. The private sector is growing rapidly, like 2/3 of 1.55 million beds, or 55,000 beds in India in 2010. Nearly 2/3 were in private sector, this is my slide actually, and then 2/3 are in private sector of total beds. The key thing was between 2002 to 2010, in 8 years, around 800,000 beds were added, hospital beds were added in India. Out of those 800,000, nearly 80% of the beds were in private sector. So private sector is a reality, it's a major provider, it's growing rapidly. When we know that public sector has a limited resources and private sector is a reality, there had to be some mechanism by which private sector could be utilized to providing or increasing access to health services. And this has been done in many, not many, but some areas at small level. For example, emergency care, emergency transport, TB, malaria, HIV, pharmacy stores. So there are some examples, and these are very well-known contract models where health facilities are given to manage by a private sector. But the point is, perhaps it has not received the kind of attention which it should have. So this slide, which you don't have to read, summarize some of the examples that how private sector has been engaged. But the point here in this slide is, they are very small initiatives covering 100,000, 200,000 population, when India has 1,200 million people. So these initiatives, which are very small scale, perhaps insufficient to achieve any major dent. And there are various types of public-private partnership which could be there. But contract or service delivery models are more common in India. This is theoretical. I'll skip this thing. I'll come to the main issue in public-private partnership in India. The challenges which are identified by the expert. This is, I have put on the slide, but these are identified by the expert. That majority of time, any interaction with private sector is seen as a public-private partnership. So which is not the public-private partnership. Any interaction with the private sector is not public-private partnership. It's a defined activity where both sides understand their responsibilities. They have some accountable mechanism of sustained engagement. So the first challenge in India that people have not sufficiently, especially the people who are engaged in formulating such partnership, have not defined that what is public-private partnership, what should be called, and what should be the key principles of public-private partnership. Second thing is that the systems are often not prepared to design the contracts or institutional mechanisms for engaging private sector. Process adopted for engaging private sector are often individual based, that some individual who is self-motivated or some government who believes that this should be done, this is done, but the moment that officer is transferred or the government is gone, that partnership fails apart because there are no institutional mechanisms. There are not enough capacity within government system or within the overall system to manage those contracts which are signed with public-private sector, and lack of policy institutional framework. So these are the challenges. And unless those challenges are improved, this is not going to work. There are some, like this is identified by expert, I have put on the slide, that the first thing, if India want to utilize the existing private sector for public-private partnership or increasing access, is that there has to be a policy formulation on how to engage private sector in with the public partnership. So health sector need to define a policy, create some institutional mechanism to design those contracts, build the capacity in contract management, utilize that partnership for certification or accreditation of those initiatives to hand over some primary health center in rural area to some NGO. Some NGOs are already running those PPP partnership. And I want to utilize this platform of academic institution or some of the researchers and students who are sitting here, that perhaps you all, this community, can think of what could be the more systematic and institutional mechanism to create objective evaluation of these partnerships. Bring this evidence, so which could be utilized by the governments and institutions to strengthen those partnerships. Because in the next slide, I summarize that what is the situation of public-private partnership in India. Many times people say that this public-private partnership has not worked in any area. When you bring any discussion on PPP in health sector and some topic, and they say, no, it has not worked in that area, it has not worked in that area. Or they are cynical or they are too optimistic. But the situation or ground reality that this is somebody has written, I've quoted, his name is Venkatraman's article. He said that in Indian setting, there are not enough empirical and objective evaluation of public-private partnership to arrive on a convincing and fair assessment of PPP. Therefore, the appropriate institutional mechanisms are required. Without that, it would be unfair to say that PPP in health sector does not work in India or does work. And especially when there is a momentum to engage on PPP, there is perhaps academic community need to work in that direction to provide that kind of objective and really strong evidence to say whatever they want to say, whether it works or not work, but it should be said with a convincing authority, with a systematic evaluation. And perhaps this group can play a role in that. Those were the key points, and that's my summary of my presentation, which I would say that SDGs are new reality, and they are going to guide the development process in India and globally. SDG provide the platform for universal health coverage related discourse in India. Urban health need to be strengthened if we want to achieve toward UHC, and PPP has a possible and definitive role in increasing access to universal health coverage in India. Thank you very much.
Thank you, Dr. Chandrakant. I think you have given us a lot of food for thought after the tea break. And may I now request Mr. Daniel to, Irina? Okay, Dr. Irina to make her presentation.
So Dr. Irina moves toward podium. I would introduce her briefly. Dr. Irina Papiva is a technical officer at WHO Country Office for India. She has nearly a decade's experience in health systems and universal health coverage and emergency. She has been working in many areas, but currently she focuses on universal health coverage, quality of health services, and health system strengthening in India. She has been engaged with the government of Rajasthan on advancing UHC in the state as well for last 1 year. Dr. Irina.
Thank you very much, dear Chandrakant. A little bit complicated introduction, but I am much more simple. I am just Dr. Irina, who is here in India to help you to progress towards universal health coverage, as simple as that. Anyway, thank you. So, what I will talk about is about the definition of UHC, which was already presented by my colleague, but not per se. I will point out about the policy goals that are embedded in the definition, and I will talk a little bit about the challenges that many governments so far have been facing while implementing universal health coverage reforms. Then I will briefly present you the first global monitoring report that was released in June 2015 by WHO and World Bank that was trying actually to assess the progress the countries has made so far in progressing towards UHC. Throughout my presentation, I will be questioning many challenges. I will be questioning many underlying problems, and I will be questioning the way how to move forward. Be ready to think. The questions are not for the answers to be provided by you or by me or by my colleagues immediately right now, but rather to prompt you think a little bit further in your everyday work. What will be the way to move forward from now on? Then I will present briefly the health system framework with key definitions, concepts, and their interrelationships and their relevance to UHC. And then I will conclude with some key and simple messages that I do hope you will take forward in your daily work, and that will be somehow helpful in designing and implementing UHC-related reforms. So our famous cube, which is broadly defined as UHC, that means that all people receive quality health services they need without experiencing financial hardship by utilizing them. And definition itself embodies three exact policy goals. One is about equity in the use of services, another one is about financial protection, and the third one about the access to quality health services. Translating this broad concept of universal health coverage to these specific policy goals is the very important step actually in designing and implementing reforms across all those dimensions, as well as in designing broader health system reforms. It's clear that there was a broad consensus among national and international stakeholders about the importance of UHC, and the interest of proving that importance is growing day by day, and it is undeniable that many countries across the world have embraced this concept so profoundly and so deeply that any reform processes that have been implemented in those countries within the health sector or outside the health sector were somehow aimed at progressing UHC or linked to the UHC concept. And now, when UHC was accepted by the member states of the WHO as one of the targets of the Sustainable Development Goals, actually a couple of days back, it is clear that mobilization of resources and efforts will take even higher speed. However, we have to accept that this UHC journey so far wasn't smooth and simple, and it will not be smooth and simple even from now on. Many countries, especially low and middle income countries, now committing themselves to the overall idea, sometimes are balancing that commitment by the concern on how to move forward. So there are many challenges here, and challenges in implementing UHC-supported reforms ranges from political to purely technical. For example, many stakeholders until now think that the UHC concept is very diffuse. Many low and middle income countries that are currently undertaking efforts in progressing towards UHC are confronted with multiple policy options. Indeed, the concept itself doesn't provide one-size-fits-all strategic directions. For example, some countries are committed to extending universality of health coverage while at the same time increasing the types of services they provide. Other groups of countries have attempted to implement their priority health services interventions based on the burden of disease in pursuit of effectiveness and efficiency, given some budgetary concerns. Another group of countries, for example, has chosen to implement priority health services packages by scaling up universal health programs of such issues that are very much relevant to disadvantaged groups, like maternal and child health programs or many different public health and preventive programs. Another challenge that the governments has been facing is, as was mentioned by my colleague already, is that the concept is referred to as direction, but not a destination, which by default means that the process is continuous, process is very dynamic, and process should definitely be responsive to constantly changing epidemiological, technological, institutional, and even political reality. Another challenge that was actually articulated by many governments is the fact that UHC-related progress is unquantifiable. And whatever we do within the frames of UHC under the umbrella of UHC cannot be precisely tracked and quantified. For example, sourcing reliable data to show the coverage, health services coverage or financial protection coverage, then disaggregating this data to understand inequity concerns or to measure effective coverage, the very powerful concept of health systems and of universal health coverage, which is about measuring, which includes actually not only measuring that the services were provided to the population, but also to take into account the quality of those services and their possible impact on health. The list of challenges is not exhaustive, and it can be actually filled by each of us as soon as we progress. But what is important here to understand that while some challenges and some questions will remain unanswered and unaddressed, like a definition of UHC, what can we do about that? Nothing. While other challenges, for example, the unquantifiable progress, can be somehow addressed as soon as we proceed with implementation of reforms to progress towards universal health coverage. In June 2015, the report, which is called Tracking Universal Health Coverage, was released by the joint efforts of WHO and World Bank. And actually it is the first of its kind to measure health service coverage and financial protection to assess countries' progress towards UHC. The report looked at global access to essential health services, including family planning, antenatal care, child immunization, TB treatment, antiretroviral treatment, and access to clean water and sanitation. The report is publicly available, and I think that you will find this reading very interesting, so I am not going to present the indicators that you can easily find online, but I want to highlight here just two things. So far, 400 million people don't have access to essential health services, and 6% of people in low and middle-income countries are tipped into or pushed farther into extreme poverty because of health spending. While preparing my presentation, I was thinking, should I present some India-specific indicators? Am I in a position to tell you about your indicators and areas where you are lagging behind? I think no. You know better than me. However, I decided to show you just one slide where you will see India's contribution to global burden of some selected conditions, some selected diseases. And please pay attention to the newborn deaths, to the under 5 mortality deaths, to the maternal deaths, and to extreme poor. Then please, let's think about the following. How does one rate a health system that attracts medical tourism for its high quality, low cost, advanced care, even as it lags behind many developing countries on key health indicators? Another paradox. How it can be accepted that Indian healthcare workers, mostly successful and prosperous, can be found almost in every corner of the world, while India itself faces incredible scarcity of human resources across the whole country. Again, paradox. What can we make of a country that has become the global pharmacy for myriad inexpensive drugs, but allows 63 million of its people to sink into poverty each year as a result of unaffordable healthcare costs? Paradox of the health system indeed. And this is the question, actually the questions I am asking myself every day. I am going to the bed with those questions, I am waking up in the morning with those questions, and I cannot believe that it is happening here in India when you have incredible capacity. You have so huge potential here to show incredible results. You are showing, definitely we are progressing. We cannot say that we are not progressing at all, but still I believe India can do much more in this area. So, health systems, what is the problem actually? Maybe we cannot address new challenges and we cannot set priorities given epidemiological, political, technical and institutional trends. Maybe we are not able to manage multiple objectives and competing demands. Maybe we don't have common understanding of what a health system is and what activities are meant in health system strengthening. Maybe we are not able to apply systems thinking to analyze weaknesses and constraints of our own system. Maybe we cannot refine policy objectives because we like to follow inertia and we don't want to emphasize some neglected policy objectives because it will take some efforts to do so. maybe we don't understand what works for whom and under what circumstances. Rather, we know only what works. Maybe we are not able to understand the wider effects of every interventions we are proposing to the government. Maybe we cannot design interventions with positive effects on the overall health system and strengthen the overall system to have positive effects on every intervention. Maybe we are not able to measure and monitor progress. So those are questions, again, that are not required immediate answers. And I don't know the answer either. So these questions are posed now to prompt your thinking in a little bit critical and innovative way. So we come to the notion of the health system now. Health system consists of all organizations, people and institutions producing actions whose primary intent is to promote, restore and maintain health. It includes efforts to influence determinants of health as well as more direct health improving activities. Health system is therefore much more than a pyramid of publicly owned facilities that deliver personal health services. It includes, for example, the mother who cares about the child at home. It includes insurance companies. It includes private providers. It includes behavior change programs, vector control campaigns. It includes occupational health legislation. It includes intersectoral actions by health staff, for example, encouraging the Ministry of Health to put more emphasis on women education, so forth and so forth. The term is really encompassing. And despite the global consensus that health systems are very much important in any endeavor and especially in progressing towards UHC, there is no single framework that will tell you how to do so. The framework that is presented now here in front of you is just one of the ways to think differently. And just for you to remember, this is probably that kind of framework that already written in English, it should be read as it is written in Arabic. It should be read from the right to the left. So on the right side, you see the goals of the system. And we know, probably, that all organizations, institutions, and resources that constitute the health system in each country pursue good health as its main goal, not only in terms of level, but also in terms of distribution, making equity concept in health a genuine objective of social progress. In addition to health gain and equity, the genuine health system goals are the following: financial protection against the catastrophic consequences of healthcare costs and a more equitable distribution of the burden of funding the system, responsiveness to people's non-medical expectations in terms of respect for the individual and client orientation. And the fourth goal is about efficient performance, achieving the best results at the lowest costs by efficiency in the organization and delivery of health services and in the administration of the system. Going further from the right to the left, we see that the above goals can only be reached through achieving a set of intermediate objectives. And those intermediate objectives are as follows. It's about acceptability, how well the health system meets citizens' expectations. It's about access, that was articulated many times today in the morning, whether or not patients can obtain the services they need at the right place and time. It's about appropriateness of healthcare, whether it is relevant to the needs and is based on established standards. It's about competence, knowledge and skills of caregivers appropriate to the care they are providing. Again, concept that was discussed already today in the morning. It's about continuity of care, how services fit together, including coordination, integration, and ease of navigation. It's about effectiveness, how well individual services work and how they affect health. It's about efficiency often conceived as technical efficiency or achieving best results at the lowest cost. And it is about sustainability, systems' capacity to provide infrastructure such as workforce, facilities and equipment, and be innovative and respond to emerging needs. Two notions that summarizes the rest of intermediate objectives and encompass financial and physical access, quality and continuity of care are effective coverage, which I talked a little bit in the beginning of my presentation. It's about probability that individuals will obtain a health care intervention if they need it, and they will derive benefit from it. And the second concept is technical efficiency, which is about making the best use of available resources. The framework, again, moving from the right to the left, described, goes beyond structural approaches to incorporate a functional perspective. And on the left side, you see the functions, which is a group of interdependent activities that every health system undertakes in order to achieve its goals. 4 of these determine the way inputs to the systems are transformed into outputs and outcomes. So the health system functions are 4. Provision of health services addressed to individual and to the groups, financing of the services, including revenue collection, fund pooling and purchasing, generating necessary resources, personnel, technologies, facilities, equipment to ensure sustainability, and finally the governance, stewardship or oversight, which is about planning, regulation, and intelligence building of the entire health system. Now, when you have an overall understanding of the health framework, you may ask the question, so what is most important for UHC? Is it about the goals the health system pursue? Is it about selected inputs to the system? For example, we have discussed human resources for health, capacity building, private-public partnership, infrastructure development, etc. Is it about particular function the health system should perform and we should put more emphasis on strengthening that particular function? Is it about selected group of intermediate objectives or interrelation between all elements? Again, questions for you, think about that. For me, it's about everything. However, for the concept of universal health coverage, I want to emphasize the concept of effective coverage. And I have been referring to this concept already twice in my presentation. So, effective coverage, just to remind you, it's a probability that individuals will obtain a quality healthcare intervention if they need it, and they will derive benefit from it. This is the concept which incorporates 3 concepts in it: demand, access, and quality. And measuring coverage with quality of care is at the heart of the UHC endeavor. Just remember that. So, the fundamental and instrumental goals and functions described in this famous framework are generic in a sense that they apply to every health system. Such a broad interpretation is simply the starting point for systematic reforms of a health system in any particular country. The framework becomes operational only when the goals and objectives are translated into the national context, and then strategies are defined to reorganize the functions to achieve those objectives. The process of translating the generic framework to a specific country context requires considerable time and effort, but it is not conceptually complex. Indeed, it can be relatively simple, linear process of moving from global goals from the right to the concrete measurable objectives from the right to the left. As this translation process continues, it provides a mechanism for stakeholder engagement as well as movement toward objectives amenable to policy action. This is the real purpose of this framework, to provide a means to organize thinking in a comprehensive, coherent manner that provides a basis for action. A lot of theory, I know that you are bored, but I am happy that just after me, my colleague will talk a little bit about how to apply the same framework into reality. And the fact that it might seem very difficult, but in reality it is not difficult, it's very simple. It is really require a little bit different way of thinking, of approaching problem, and it requires a little bit of time, definitely. So, in conclusion, for you to remember, UHC is a direction, it is not a destination. Applying system thinking in designing and implementing UHC-related reforms is a necessity. Operationalizing the framework to country-specific objectives is a requirement. And being ready to accept reality and to overcome inertia is a prerequisite for all of us. And definitely investing in wider health reforms and overall health system strengthening is a commitment. So I want to conclude my presentation with the words of Mahatma Gandhi. Yesterday we celebrated his birthday, and definitely I like quotes in general, and I have a huge collection, but for today and for this particular agenda I have chosen this one. Be the change that you wish to see in the world. And I'm very happy to see today in the audience young generation. So I strongly believe that you will be taking over this change. And as soon as you are committed, as soon as you understand how to move forward, you will change the world. So I wish you good luck and thank you.
So thank you very much, Irina. So a very wonderful presentation. She outlined that USC is a goal, but then the tools or strategy to achieve that USC through health system. So continuing this discussion is my colleague, Mr. Daniel Ernesto Albrecht Alba. He's a technical officer on health system with WHO Country Office for India. Before joining WHO Country Office, he was in Mexico and then WHO headquartered in Geneva. He had led many projects in public health in large number of countries. He currently, while working in India, is collaborating with the government of Kerala on a 3-year technical cooperation program on health system strengthening with a focus on non-communicable diseases. So over to Daniel.
Thank you very much for your presentation, Chandrakant. Thank you for the audience. I am very excited to be here in front of so many students, future thinkers, actual thinkers, the students that are willing to think out of the box, students that are going to be leaders in this country. My presentation basically tries to make these issues, these concepts that we usually think about in terms of frameworks, in terms of guidelines, in terms of gold standards, which is very common in my work environment, to make doable. By the way, I don't come from medical science. I did political science. My understanding of public health is basically in terms of what can be implemented and what is possible to do in a complex environment. So this is India. I don't want to enter into details into India. You know all these facts. We are the largest economy, GDP is growing, FDI is growing, per capita GDP is growing, but still we have 400 million people on the poverty line, if not more. And there is also, as Irina says, 63 million people last year going to poverty because of medical expenses. This is the health system in India that also you already know. The system, it's, to start with, is a very low government expenditure in health, very high out-of-pocket expenditure. The system is fragmented, is segmented, is private sector, public sector, private sector doing provision, doing financing, doing influence and regulation. I mean, several areas in which you don't have different maybe you can close the door over there. There are several areas in which you don't have clear roles in the system in India. There is no integrated care. Primary health care service is weak. As a result, you have low quality of services, as reported by most surveys. Well, there is insufficient human resources. This is an issue. As you may know, 70% of graduates from AIMS in this country are living abroad, which is an indicator of the system, how the system is catering to the best professionals in India. This is the double burden of disease in India. I'm not going to enter into more details. We have a very high level of non-communicable diseases. However, we still have maternal mortality, infant mortality, and infectious diseases on very high levels. More about India: anemia, immunization, not going fast enough, MCH indicators that are very high. We have almost double the number of cases of diabetes in 10 years. Sorry, in cardiovascular disease in 10 years. We have 50% increase in diabetes in 10 years. Between 2005 and 2015, we have a very serious problem for NCDs. At the same time, this is a scenario in India compared to other countries of the same level of income or size or political affiliation like BRICS. No? Availability of health services is, hospital per bed is low compared to Thailand and Brazil. The same for doctor ratios or antenatal care. This is influencing in quality. This is quality in, I would say, the best performer in health systems in India. The case of Kerala, for example, it's a case that I would like to highlight how quality is being perceived or undermined. This is deliveries in public facilities per district in Kerala, and more of them are over 15% of deliveries that is, as recommended by WHO, should be C-sections. So what is the problem in India? I'm not pretending to give answers to a problem that is by itself complex in any country, but in India it's even more complex because it is 26 countries plus 10 UTs, 1.3 billion people. So my understanding of the situation in India is basically that we have strong determinants of health working outside the health sector that put a lot of vulnerability in the population. You have education, social exclusion, caste inequality, access to water, sanitation. So this is an issue that lies outside the health sector mostly. You have a weak health system that is not able to provide services to all the population. Also, you have very low financing. What is the response of WHO? WHO proposes UHC, as explained by Chandrakan and my colleagues, Chandrakan and Irina. But this is the response of we want to do in WHO. This is a challenge, because this is what we want to do, universal health coverage. We know that. But this is the most challenging situation for any person coming from social science, working in public health, working in WHO, working in India, myself. It's very important to understand what is possible to do in India, how we engage different actors, and how different actors think out of the box. How you students start to think out of the box, how my colleagues here in front start to think out of the box, what is possible to do, and who have to do what. I'm taking three people actually mentioned this morning a key word that for me was very important. Dr. Jain mentioned that we need a strong health regulatory system. We need a state. One of the students over there mentioned the same. What is the role of the state? And Dr. Rakesh Kumar mentioned the same. So my work in India is try to advise the government what is possible to do, how we can all together think about the system, how we can start doing universal health coverage. I'm not going to explain the box, because the box is the same as, it haven't changed between Chandrakan and Irina, it's the same box. So how we implement the box in the last district of Bihar to achieve better coverage is going to be different how you implement in Tamil Nadu or how you implement in Rajasthan. But the key axes are the same. You can have populations that are you going to expand the system. You can have better services that you are not providing, or you can reduce the financial burden of healthcare, accessing to healthcare in the households. So more or less what we want to do when we propose something working on health systems is, first of all, let's think about what we can do in the system, within the system, what we want to do as public health practitioners, medical doctors, managers, and what we can do outside the health sector. I mention this because many times we talk about social determinants of health, health in all policies, intersectoral action, but actually the first thing we have to do, in my opinion, is to first think about what we can do in the health sector, how we have to put order in the health sector to achieve coverage. So basically what it's coming from the books in India, again, this is books. It's we have evidence-based interventions, the verticalization of programs, because India is a mix of silos. We need quality improvement, for sure, we need quality improvement, and we need continuity of care. And we need something that more or less is understood. We are not going to measure the system, the success of the system, not because we have a network of facilities or because we have a strong primary healthcare system. We are going to be accountable as a policy maker because we are increasing access and effective coverage. No? Then we can go to do, in my opinion, you can start doing intersectoral action and all these issues that are not my first professional training. So for this kind of interventions, the first 3 or 4, we have health system approaches that are basically applying the health system model that we are going to discuss later. And for this, we have social determinants approaches. My focus, when I work in India as a health systems advisor, is to try to do how we have to integrate, how we have to ensure quality, how we have to ensure access, and how we can do continuity of care. So this is a framework that Irina mentioned before. We have inputs and health system functions, and these health system functions are going to be combined in a way that we improve access, utilization of continuity of care, quality and efficiency. Why I'm just mentioning these 2 areas? Because when you work in policy, I prefer not to go to ultimate goals. I prefer to stop saying, okay, we are going to combine these functions to improve access, to do better continuity of care, to improve quality and efficiency. If we can reach that in a specific policy environment, we are doing a lot. If we put the barrier too high, we are not going to be able even to start. And I will tell you why. If you start to approach a policymaker and said, oh, we have to increase the level of responsiveness, okay, better, let's say, we have to better increase utilization. Let's focus on what is doable, what is achievable, instead of going to ultimate goals. This is something that I think is going to be shown in the next slides, but I'm not saying this is not important. What I'm saying is when you do policy work, when you approach the decision maker, you try to do something feasible and be gradual, be incremental, instead of going with big discourse and not being able to deliver what you are expected. So to more or less do a summary so far is we are going to measure our success by improving access, but at the same time, there is no unique model of UHC. As I said, this is a 26 country in 1 country. So we have to adapt. We have to add ideas in what is feasible. So what I've been done in the past, well, this is the rationale of the framework, which I'm not going to explain, again, the framework. So my point is, please be focused on functions and intermediate objectives, because this is experience that we try to implement in 2 countries, and also we are trying to implement in Kerala. So what is the idea? When we were asked to advise a government to implement a universal health coverage experience strategy, we immediately understood that we have to be simple. We have to make a gradual process in which the process is owned by the government. This is what we're trying to do in Kerala as well. So we said, okay, let's do something that is called the health needs assessment. What are we going to do with the health needs assessment is basically 3 objectives, which are very important. So we want to know what is the situation, the health situation of the population we want to work with. Okay? Then we want to identify how the health system is responding to that situation in order to reorient the services. And then, which is more important, beyond these first 2 components is to engage, to trigger a policy process, to make policymakers and decision makers interested that improving health is going to be good. I'm going to be very, very honest here. It's going to be good for the population and for them. Because policymakers are politicians. Politicians think in 2 levels. The technical level, what is going to be good for the population, and what is going to be good for them also. This is a reality. I'm a political scientist. If you think I'm saying something which is not correct, I'm willing to debate, but it's reality. So we have to adapt our discourses, our frameworks, our gold standards, our evidence to something clearly articulated in terms of it's going to be good for the population, it's going to be good for the government. And with this, I'm not being doing party politics. I'm making a technical work. But you have to be able, especially the students, to understand that science, when you go to policy, is not anymore science. It's 50% science, 50% politics. And you have to be able to navigate the system and understand, make clear that the decision maker is going to be clear that is going to benefit both levels. Okay? This is very important because all this process of health needs assessment, the health needs assessment is a publication, a very nice publication that I think so far is 200 pages. It's going to be published. It's very nice. It's going to be published. Fine. But I don't do the work for the publication. I have enough publications. I don't do the work for the publication. I do the work because this document is going to start a policy engagement. It's going to be a process in which the policymaker is going to, first of all, own the product. It's going to be signed by the policymaker. It's going to be signed, it's going to be done by the policymaker with the assistance of WHO, okay? But why we need to do assess health? Because of this concept of public health that all of you know, I know. You have to know that what you are choosing, a state or a jurisdiction or even a district, is going to be strategic. I'm not saying why, but I will say why later. It's going to be strategic. It's going to provide, it's going to start a process, okay? You have the resources for sure, and you can, and it's feasible, okay? Then you start to look at what are the main issues happening in the state. You have population profile, you have what are the health conditions that are common in the population, and what is the response of the system as such. For this is that we start to interact with the frameworks and the guidelines and the gold standards to know if, for example, you have enough